All right, let's just get right into it. Welcome to this explainer where we are taking a really fascinating journey from the absolute surface of the skin all the way down into its deepest layers. We're tackling clinical bacterial skin infections today. Now, I know, at first glance, that might seem like a pretty straightforward topic, right? Just rashes and bugs. But it's actually this incredible, complex study in anatomy, geography, and microbiology all working together. We're going to explore exactly how these bacteria interact with our body's primary shield.
But before we go geeking out over the anatomy, let's ground this in a real-world scenario. Picture this. You've got a 7-year-old boy, and he shows up with a 3-day history of a facial rash. It doesn't really hurt, but he says it occasionally burns and it's super itchy. His parents already tried throwing some over-the-counter steroid cream at it, but it did absolutely nothing. So here's the big question. What separates a simple, pesky itch like this from a legit medical emergency? How do we actually know if it's harmless or dangerous? Well, the secret lies in figuring out exactly where the battle between the bacteria and the body's happening.
To make sense of all these different pathogens, we're going to use a structural map. We'll start with surface infections and skin layers, then move down to the deeper dermis and subcutaneous tissue, look into hair follicles and sweat glands, pivot to chronic invaders like TB and leprosy, and finally wrap it up with our essential clinical takeaways.
Starting off with Section 1, Surface Infections and Skin Layers.
Okay, so the absolute most crucial thing to remember here is that dermatology, it's basically real estate. It's all about location, location, location. If you know the neighborhood, you know exactly how the disease is going to act. At the very top, in the penthouse, we have the epidermis, specifically the stratum corneum. Just below that is the upper dermis, which is where your lymphatics live. And then further down, we hit the lower dermis and the subcutaneous fat. Think of those as the deep foundational layers, kind of like the basement of your skin. If you can clearly visualize these distinct layers, everything we're about to talk about is going to make perfect, logical sense.
Bringing it back to that 7-year-old boy we mentioned earlier, his presentation of perioral vesicles and papules covered in those classic honey-colored crusts. That is the absolute hallmark of impetigo. This infection is living right up in that penthouse layer, the stratum corneum, the most superficial layer of the epidermis. And because it's sitting right there on the surface, it is incredibly contagious, especially in warm, moist environments or where hygiene might be lacking. Usually, it needs some sort of predisposing skin damage to get a foothold. A minor scrape or an underlying condition like eczema is just enough of an opening to let the primary culprits, Staph aureus and Strep pyogenes, sneak right in.
Now, what's really fascinating here is how these exact same bacteria can cause two completely distinct visual patterns, and it's all based entirely on what they do to the skin cells. On one hand, we have non-bullous impetigo. This is the big one, accounting for about 70% of cases. It features oozing secretions that eventually dry out into those signature honey-colored crusts we just talked about. You mostly see this in older kids, and the good news is it heals up without scarring. On the other hand, making up the other 30% is bullous impetigo. We typically see this one in infants and toddlers under 2 years old. This form is driven purely by Staph aureus. The bacteria produce these wild toxins that literally split the cellular bonds. They're called desmosomes, just tearing them apart like unzipping a jacket. This creates large, flaccid bullae, or blisters, which ultimately pop and leave behind thin, brown crusts. It is a stark visual difference, and it all comes down to the specific bacterial toxin at play.
So, how do we fix it? Treating this surface invader is pretty straightforward and follows a very logical 1-2 punch of clearing the debris and attacking the bacteria. Step 1 is simply physically removing the crusts with some gentle washing. You have to clear the battlefield, Otherwise, your treatments can't actually penetrate the skin. Step 2 is going in with topical antibiotics, specifically mupirocin or fusidic acid, which are perfect for targeting both staph and strep. And finally, step 3, for the severe or really widespread cases, you bring in systemic or oral antibiotics like cloxicillin or cephalexin. We absolutely must treat this thoroughly because left untreated, these seemingly simple surface infections can actually trigger rare but super serious complications later on.
All right, moving deeper. Section 2, deeper dermis and subcutaneous tissue.
This right here is the ultimate spatial test. We're comparing two non-purulent infections, erysipelas and cellulitis. Erysipelas is an infection of the upper dermis. Because it's sitting higher up, right near the surface, its edges are sharply demarcated and highly defined. Seriously, you could literally take a Sharpie and draw a line exactly where the red, swollen skin stops. But cellulitis? That lives all the way down in the lower dermis and subcutaneous fat. Because that infection is buried deep beneath the surface, when you look at it from the top down, the edges look ill-defined and blurry. Both of them give you redness, swelling, and pain, very often on the legs, but that one visual clue, sharp versus blurry borders, instantly tells you exactly how deep the bacteria have invaded. And while we're talking about deeper implications, we really have to watch out for remote toxins. A huge example is staphylococcal scalded skin syndrome, or SSS. Guys, this is a true skin emergency, mostly seen in newborns. What happens is you have a localized Staph aureus infection somewhere else entirely, like down in the pharynx. But that infection acts like a launch pad, releasing an exfoliative toxin into the bloodstream. This toxin travels like a heat-seeking missile all the way to the skin and just splits the epidermis right at the granular cell layer. The baby gets this generalized redness, extreme tenderness, and eventually the skin desquamates. It literally peels away in these large sheets. It looks exactly like a scalded burn, though interestingly, it spares the mucous membranes. It looks absolutely terrifying, but because it's toxin-mediated and not a direct bacterial invasion of the skin itself, it usually heals up within a few days once you treat the underlying infection with systemic antibiotics and give supportive fluid therapy.
Bypassing the flat layers for a second, let's hit section 3, hair follicles and sweat glands.
Let's zoom in on the specific anatomical pockets where bacteria really love to hide out, our hair follicles. We start with the mildest battleground, which is superficial folliculitis. This is a localized inflammation of the hair follicle that stays strictly limited to the epidermis. Visually, you're looking at multiple tender papules and pustules popping up right at the root of the hair. You're going to see this all the time in the beard area, the axilla, or on the extremities. It's so frequently triggered by simple things like shaving, friction, or just sweating. Usually, good hygiene, some warm compresses, and antibacterial soaps will clear it up really quickly without much fuss at all.
But, if that bacteria decides to travel further down the hair shaft, things get nasty. It morphs into a much more painful furuncle, which most people just call a boil. This is a deep form of folliculitis that typically involves the entire hair follicle and even bleeds over into the surrounding subcutaneous tissue. It's a much more entrenched infection, and it's almost entirely caused by Staph aureus. Actually, scratch that. It is overwhelmingly driven by Staph aureus, and it creates this deeper, highly tender nodule that can absolutely leave scar tissue if it gets severe enough.
And what if things get totally out of hand? If multiple boils decide to join forces and coalesce into one massive, deep-seated infection, you've got a carbuncle. This is a collection of boils in a single area, and it features multiple draining sites. It's intense. When an infection reaches this level of structural complexity, oral antibiotics alone just aren't going to cut it. The absolute best treatment for these complex, deep-skinned abscesses is physical intervention. You specifically need an incision and drainage to physically open up that pocket and clear out the trapped infection, paired, of course, with the right systemic antibiotics. Quick clinical sidebar, though, because this is a classic trap. Not everything that looks like an infection actually is one. Pseudofolliculitis is a major differential diagnosis we have to keep in mind. This is a non-infectious, foreign body reaction to a tightly curled, ingrown hair. People who are genetically inclined to have spiral, curly hair might find that after they shave, the hair literally curls back around and pierces its own skin. The body freaks out, causing intense irritation and inflammation. It looks incredibly similar to a bacterial infection, but it's really just the skin throwing a fit over an ingrown hair. They don't need antibiotics, they just need a break from shaving for like 6 weeks or to switch to a specialized razor.
Shifting gears completely away from the acute stuff. Section 4, Chronic Invaders, TB and Leprosy.
So tuberculosis, right? We always think lungs, but TB can create these wild, completely different manifestations on the skin, and it is heavily dependent on how the patient's immune system is reacting. Looking at the breakdown here, lupus vulgaris is the most common type. You see this in patients with high immunity, and it shows up as these chronic red-brown plaques. And if you do a technique called diascopy, where you press a glass slide right against the skin, it reveals these classic yellowish apple jelly nodules. It's wild. Then you have miliary TB. This is from hematogenous or bloodborne spread, typically happening in immunosuppressed patients. It pops up as small papules with central crusting. Then there's warty TB or TB vericocutis. This is famously known as the anatomist wart. It happens when someone with prior immunity gets directly inoculated. Think physicians or pathologists handling infected tissue. Finally, scrofuloderma. This happens from the direct extension of TB bacilli from an underlying infected lymph node or bone, pushing up to form a firm nodule that eventually ulcerates into a draining sinus. The way it presents is entirely dictated by the host's immune status and how the bacteria got in.
And when we look at leprosy or Hansen's disease, this table right here is an incredibly powerful memory tool. It brilliantly contrasts how a strong immune system keeps leprosy localized, while a weak one just lets it spread symmetrically all over the body. On the left, we have tuberculoid leprosy. Here, the patient's immune status is strong. The body fights back, limiting the disease to just a few localized hyperesthetic, meaning highly sensitive, skin lesions.
Because the immune system is actively clearing the bacteria out, the acid-fast stain actually comes back negative. It's paucibacillary, meaning very few bugs are there. Treatment is around 6 months. But conversely, on the right, look at lepromatous leprosy. This happens when the immune system is weak. The bacteria multiply totally unchecked, resulting in multiple, generalized, symmetrical nodules. They can even clump together on the face to cause what's known as leonine facies, literally a lion-like facial appearance. Here, the stain is overwhelmingly positive, it's multibacillary, and you're looking at a much longer 12-month treatment regimen. In these chronic infections, the immune system is the ultimate architect of the disease.
All right, let's bring it all together. Section 5. Essential clinical takeaways.
We've covered a ton of ground, so let's rapid-fire the absolute must-know facts from this explainer. This is your ultimate cheat sheet. If you memorize these distinct visual clues, you will always know exactly where the pathogen is hiding out. Number 1. Impetigo sits right at the surface in the stratum corneum and gives you those classic golden, honey-colored crusts. Number 2, if you see multiple deep ulcers with crusts stuck to them, that's ecthema. It's literally just a deeper, ulcerating form of impetigo that's pushed further down into the dermis. Number 3, remember the blur test? Erysipelas is in the upper dermis, so it has a razor-sharp demarcation. Cellulitis is in the deep dermis and fat, so it looks blurry and ill-defined from the surface. And finally, number 4, for those deep skin abscesses, like carbuncles, throwing antibiotics at it alone usually isn't enough. They absolutely need a physical incision and drainage.
So, bringing it all home to where we started. Next time you see a rash, are you just going to look at the surface, or will you stop and ask yourself exactly how deep that microscopic battle is really going? By mapping these symptoms directly to the layers of the skin, we can take what looks like a totally confusing array of rashes and turn it into a highly logical, predictable science. Hopefully, this spatial approach fundamentally transforms how you view our skin's incredible defense system. Thanks for joining me on this deep dive. Keep questioning, keep learning, and I'll catch you in the next explainer.